Let me introduce next speaker is Ahmad from United States. He will introduce his first experience, how to start this procedure in your center. Dr. Ahmad, please.
Hi, how's everyone doing? So I think what I'm going to do is not try to tell you how to start. I'm just going to share how I started. It might not apply to you, but just share my story, how I got around to doing this and how I met Professor Begg. So this thing will work?
Yeah, just click to the right.
All right, so this is a brief bio about me. I'm an endocrinologist by training. I've had a thyroid-only practice for the last 8 years, and I was deeply interested in minimally invasive percutaneous techniques ever since I became aware of the initial papers that were published by some of these esteemed gentlemen sitting right here. And so we've been chasing this thing for a while. And basically, these are some general numbers. Again, it's really hard to get numbers about how many thyroid surgeries are done, but most sources I tap into. How many Americans in the room? Can I get a show of hands? 1, 2, 3. So, I mean, you guys could probably correct me, but so according to my research and the different sources, including CMS, where you get some data from a couple of years ago, you'll see that they're doing close to 100,000 surgeries, thyroidectomies a year. The majority of them are for benign disease, apparently. 50 to 60,000 cancer diagnoses. The others are for different variety of reasons. Thyroid nodules, toxic goiters. So it's a pretty big problem when you scale it to the American demographic and the American population. Average cost of thyroidectomy, these are Medicare rates, $15,000. I know that most of us don't get to see that type of money, but that's how much it costs. So it's an expensive proposition. You look at how many surgeries are done. Perioperative complication rate, 8 to 24%. Again, this is from the American College of, from the Annals from a couple of years ago. They have done a nice little summary. Again, just to break down what type of things go wrong in the US reportedly with surgeries. Again, I'm not a surgeon, but 2.1% bleeding risk, 7.5% risk of voice problems, hypocalcemia, temporary or permanent, wound infection. So pretty sizable numbers. So thermal ablation in the US, we didn't really have anything up until last year. Why not? I think there were a bunch of different factors involved. There were no US-based companies with the type of funding necessary to do trials and get it approved and get the technical know-how to get that done. We did reach out to some of the companies who had pre-existing RF devices like Covidian and Medtronic, but we didn't get the type of support we needed. And again, I don't think they were geared towards thyroid procedures as much. There was no FDA approval for percutaneous outpatient tissue ablation until 2018, until StarMed came to the party. So we didn't really get anywhere, even though we were starting to look into it pretty aggressively back in 2012, 2013, trying to call everyone and anyone we could. So we started looking at microwave. There was a startup company that had a microwave device which had been used for thyroid ablation in other countries. And so we started working with them back in 2012, 2013. We were told it was cheaper, it was technically easier to learn, a bunch of things that you get told and you take it with a grain of salt, see what happens. But they were offering some support. So there were some papers published also from around the world about microwave ablation, and so we went down that path for a couple of years. We sent a bunch of letters, we sent a full protocol, and then when I realized the FDA is a huge big bureaucracy where every time we would ask them about something, we'd get like a 50-page rebuttal, and sometimes I was on a conference call while I was on one side, there were 18 people on the other side with a bunch of PhDs and engineers, and so we didn't really get anywhere. The company, the microwave, ran out of money. And then, I went to the master's course last year. So last year was the first time I got to meet the team and Dr. Begg, and we went to Seoul, spent some time there, ate a lot of really good Korean food. If you guys haven't been to Korea, check it out. Really nice destination to be. you get to learn a lot with Dr. Beg. I think in about 3-4 days you'll see more procedures than you would normally see at any other focused type of gathering like that. You get pretty comfortable with what is going on, and you learn pretty much the ins and outs of what are the essentials. And then we did our first cases in the US. First 3 were done in November 2018. We already had a list of a large list of patients that we've been compiling since we've been trying to get our percutaneous ablation thing started. So it wasn't hard to get volunteers or candidates who met the criteria. The criteria we used were what the Korean Radiological Society has. Make sure the nodule is benign, 2 benign biopsies, no metal hardware, no other comorbidities, no bleeding diatheses, and that's how we started. We did this first case, as you can see, in a surgery center, but the patient was not under. The patient had a little bit of Versed, and we did the pericapsular injection with lidocaine, as I learned from Dr. Beg. A little nerve-wracking, the first 3 cases. We were a little nervous, but we had support. These guys were all there, and it was pretty euphoric after we were done. Everything went well, and since that time, we're up to 15, I think. The last count, we do about 3 to 4 a month. Cost of RFA, I just wanted to go over this briefly. When we go to a surgery center, these are some of the challenges that I'm going to talk about when we're talking about starting this in the US. There is a lot of supply stuff that you end up paying for when you're done. Surgery center costs, and there's some other costs built in. That's one of the easily scalable barriers, but it is a barrier worth keeping in mind. Surgery center, conscious sedation, this is, again, something we're doing right now. When I was in Korea, we didn't have to do any conscious sedation. Obviously, Dr. Beg has done thousands of these, and I have not, and it takes me a little longer to finish the procedure, so I need the patient's compliance or cooperation a little more. And so we do use conscious sedation. Some of the papers from Italy, when we read, some of the experts here use conscious sedation for recurrent cancers, others don't. But for right now, we're doing it mainly because we want good results, and we want the patients to be very comfortable and no complaints. So those are some of the costs that are built into starting up a RF ablation program. Why do we need it? We obviously know the reasons for that, but just to scale it, that term that I used before, to the US population, we have a lot of people with thyroid nodules, and majority of them do not want a surgery for this. Most surgeries in the US on a ratio of 2 to 1 are done by surgeons who are not high volume surgeons. Again, that's a dangerous term to throw around because there's no good agreement on what a high volume surgeon is. But majority of the surgeries are done by people who don't have enough expertise and practice in doing thyroid surgeries, and that's why those complication numbers that I had up on the screen are, there's such a wide range. And some people have much lower complications, others have much higher complication rates. Again, same thing, repeating about how many surgeries are done in the US. Same complications. So toxic nodules are also a very common clinical problem in the endocrinology world. Several treatment options are available, but if you look at all the results that you get with RF ablation, I think someday when we look at all the data from the last 10, 15 years, we'll realize this should be the top treatment modality that we should use for toxic nodules, because it really responds very well and we get very good results. So our first case was a toxic nodule. She was a 35-year-old lady. She had a right-sided thyroid mass, which on an uptake in scan was found to be a toxic nodule. It lit up very nicely. We did biopsy it, again as per the guidelines that we follow. Even if it's a toxic nodule, you need 1 benign biopsy. We did that, and she wanted to do radiofrequency ablation. She was adamantly opposed to surgery, radioactive iodine, or any other medical therapy. This was her nodule initially. I shared these pictures with Professor Beg. Got his blessing before we started. This was the first case we did. This was her image 1 week later, and then by the time the American Association of Clinical Endocrinology meeting was up, we had a 2-month time frame, so we had full data set from her. So we presented that first case at the ACE meeting recently. Did we say pointer in here? The laser pointer on? This thing right here? Oh yeah, here we go. So as you can see, I wish I could blow this up more, but by the end of 2 months, it went from here to this to pretty much nothing. And we had like a 97% reduction in size, and we had normalized TFTs within the first 6 weeks. This was the first toxic nodule we did. Since that time, we've done another 4 similar results, 60 to 80% reduction in size and normalization of TFTs. Now, is this going to last? I mean, if I look at all the data sets from Italy and even South Korea, 80 to 85% of success rates have been quoted to normalize TFTs with toxic nodules. But I mean, that's a really good result. If you compare that to radioactive iodine failure rates, you can obviously see the benefits of doing something like this. So what are the indications that we're looking at in the US? Benign enlarging thyroid nodules with cosmetic or compressive symptoms. Obviously, the risk of malignancy has to be ruled out. We do 2 biopsies for a non-toxic nodule, 1 biopsy for a hot nodule that's picked up on a uptake and scan. The problems that we're running into are where do we reconcile these genetic tests before somebody wants to get RF ablation done. A lot of patients have 1 benign biopsy and 1 benign on gene sequencing classifier or the ThyroSeq2 mutation panel. And for right now, we're telling patients we need 2 cytologically benign biopsies. Where are we coming up with this? We have no idea because we don't have guidelines yet. But the negative predictive values for these tests vary from study to study. Negative predictive value quoted for a Bethesda category 4 with a gene sequencing classifier is 94%. Some people say it's 92%. ThyroSeq is all over the place. So with cytology, at least we know the negative predictive value after you've done 2 benign biopsies is much higher. So we feel a lot more comfortable doing RF ablation on those patients. Recurrent thyroid cancers, this is another thing that's going to come up again and again. It is part of the ATA guidelines. It's worth considering thermal ablation for recurrent cancers. We are hoping to do our first case for a recurrent medullary cancer in the next few weeks because the patient's had 5 surgeries already. This is a 5th recurrence, and she's no longer a surgical candidate. But again, this is still not part of our, let's say, way of doing things. So you feel a little out there on your own when you're trying to do something that hasn't routinely been done in the US. We're still going to wait for more data and guidelines from our societies as we get our data sets together, which we're working on with other people who are doing RF in the US, and hopefully we'll have better information on how to approach patients like this in the future. But it has obviously successfully been done by these gentlemen sitting here, and hopefully we can offer the same to our patients. Pain control, again, the reason as I said, I'm using conscious sedation is that patients have a better experience. We want the best data sets that we can gather, the best patient advocates we can gather for this procedure, so that it's easier to gain acceptance as we move forward. But all the patients I saw Dr. Beck doing can be done under lidocaine pericapsular injections, which we also do, by the way. But we still haven't done anything without a little bit of Versed yet. We do pay very close attention to their voice. Our protocol is to check their voice every 2 minutes, and both me and my partner are together when we do this procedure. Both endocrinologists check the voice every 2 minutes. So far, it's been pretty good. Why do we need conscious sedation again? Until my learning curve gets better and better, we're still using it again. That was what I was alluding to before. These are the first 5 patients that we have done, and this is just 2-month follow-up. So we don't have 6-month follow-up, but this is the 2-month follow-up. And as you can see, 50% reduction is the average. The first patient that I shared with you with a toxic nodule, we had a 98% reduction, but that was the outlier. As you can see, most patients did have significant reductions in volume within 2 months. So, so far so good. It's been working really well. And we've obviously been very diligent in selecting the patients in whom we can get the best responses and which are not in an anatomically compromised area where we would run into some trouble. So maybe these are not results that I can expect with all patients, but so far this is what's been going on. If you want to go ahead and start, before you start doing patients to get a sense of comfort in doing this procedure, practice the transseismic approach. If you're doing a biopsy on somebody who would be an appropriate candidate for a transseismic biopsy, because most of us do the AP approach for regular biopsies, because you don't typically do the transseismic approach routinely, at least in a thyroidology practice like mine. So practicing that does give you a lot more comfort in terms of the spatial orientation you need to get the needle and the antenna into the areas that you want. So practicing that is important. Practice the pericapsular lidocaine injection. I do that, but I have been doing that for ethanol ablations, which I've been doing for 6-7 years, but not to the extent that Dr. Bake does. He just basically does a very careful, deliberate separation of the capsule, and he injects a generous amount of lidocaine. So I started doing that as I was building up to doing my first cases. So that's another good thing to practice. Whenever it's clinically applicable, obviously practice that. And have your team together. You'll need a team approach to do this. It's not something you can do by yourself. You need an extra set of hands, you need an extra set of eyes, and working together takes a little while until you become a well-drilled machine. And practicing with them is also an important part, so that when you do the first procedure, you're not nervous, you're not uncomfortable about the location of certain things that you need while you're doing it. And the other biggest barrier is insurance coverage in the US. I don't know where that's going to end up. That discussion is ongoing. We've tried to contact a couple of insurance companies. We're going to work on getting medical approval for this patient that we're working on with the recurrent thyroid cancer. The company's trying to help us also. Dr. Park in Virginia is doing his thing. So I don't know where that's going to end up, but hopefully that will get covered, and once that happens, it'll make it much easier to offer this to our patients. But right now, the cost is one of the leading barriers. I was just going to share with you guys a video we made with our patient, and the reason we did that is a lot of your patients will probably ask you if they can talk to somebody who's had this done. That was a very common refrain we got from some of our patients, and one of the first few patients we did was generous enough to shoot a video for us, and she became an advocate for this, and I'm just going to share this with you. And go ahead.
I was diagnosed with a toxic nodule approximately 4 years ago. I lucked out in the fact that I saw Dr. Ahmad from the very beginning. My family physician actually recommended him. And so I just feel like I got so lucky in the fact that I didn't even have to search this out.
Radiofrequency ablation is a unique treatment that targets benign thyroid nodules or overactive nodules and goiters. Traditional treatment of this condition was usually done with either surgery, radioactive iodine, or suppressive treatment with thyroid hormone, each having significant risk or complication.
I chose to go with RFA for a couple of reasons. One was just the fact of not having a scar on my neck for the rest of my life. I think anybody would choose no scar over scar. Another one was the pain. I think that with this procedure there was zero pain involved versus actually having your thyroid cut out. And then also the third and the biggest reason for me was actually the fact that you most likely will not have to be on medication. Your chances of needing lifelong medication after the RFA procedure is significantly less than with the surgery. So that was, to me, a done deal once I heard about that.
At the thyroid clinic, we researched and found that non-invasive treatments had been done for many years in Europe and South Korea with positive results and without the risk of complications that worried patients. We wanted to bring this treatment and technology to our patients. With over 12,000 operations between Dr. Jamal and Ahmed, we have the successful record of procedures on the neck. We invested several years in learning and following the procedures developed in South Korea, traveling there and working next to the pioneers in this field, since we found their techniques brought about the best results with minimal risk of side effects. We are the first to offer this treatment in Utah, but are certainly not alone, with such institutions as the Mayo Clinic publishing results on the successful procedure. We recently published our results of a case where we were first in North America to successfully use this technology to to treat an autonomous and hyperactive thyroid nodule and presented the findings at the American Association of Clinical Endocrinologists. RFA is similar to other procedures done in an office setting, delivering energy right to the nodule that is causing the problem, causing internal damage to the nodule by friction. We work with a patient's endocrinologist or ENT surgeon and thoroughly review their records to make sure there is low likelihood of the nodules being cancerous. They must be benign to use this procedure. The estimated risk of hypothyroidism after the radiofrequency ablation is less than 0.1%, and working with the patient's doctors, we assure they are getting proper follow-up after their procedure.
There was no pain whatsoever with the procedure. The only thing that I felt was really kind of like when the zapping was going on the nodule, I could feel kind of like crinkling, kind of the sound of crinkling, and so I was coherent throughout the entire procedure. I could respond, I could feel everybody around me, but I was aware of everything that was happening to me during the procedure. Probably the drive home, it was tender. I would say there was tenderness, and I was, you could feel the spot where it happened, but I never even took an aspirin. I never had any pain whatsoever with the procedure.
Our basic goal is to have at least a 50% reduction in the size of the nodule after treatment, and are happy to report we have exceeded that with all of our patients to date.
I would absolutely recommend this procedure 100%, especially over surgery. I think it was so simple, no side effects, nothing to deal with, no pain, no scarring. Absolutely 100%, I would choose this procedure any day over surgery.
Thanks, guys. I'm going to sit down. I think there's a question-answer thing after this, so if there's any questions.